You're listening to Medscape's In Discussion series on systemic lupus erythematosus, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Maureen McMahon. Dr. McMahon is a professor of medicine and associate chief of rheumatology at the David Geffen School of Medicine at UCLA. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Maureen McMahon. Welcome to the Medscape In Discussion podcast series on systemic lupus erythematosus. Today we'll discuss cardiovascular disease in SLE with our guest, Dr. Michael Garshick. Dr. Garshick is a board-certified cardiologist specializing in cardiorheumatology at NYU Langone Health. He's an assistant professor in the Department of Medicine and the Ronald O. Perlman Department of Dermatology at NYU Grossman School of Medicine. Thank you for joining us today.
Yeah, thanks so much for the invitation to have a chat with you about lupus and cardiovascular disease. I'm excited to connect on the topic.
Yeah, I'm really excited to have a chance to talk to you about this. I know this is a passion of both of ours. I initially developed an interest in this area back when I was a fellow. We had a patient, she's 28 years old, and she'd been trying to exercise a lot. She'd had previous very active disease, but had been doing pretty well, but found that when she was trying to run on a treadmill, she was having chest pain and shortness of breath. And, had to present a couple times to the ER, and people thought, oh, it's your lupus. So it's, musculoskeletal, gave her some NSAIDs, gave her some steroids. And in the end, she ended up having a myocardial infarction. So that really struck me and really made a big imprint on me, the real increased risk we see in our patients. I don't know if you've had kind of similar patient experiences.
Yeah, I think what's most telling about your story is the missed diagnosis, right? Or the delay in diagnosis. I think I can tell you a number of times this has happened. And it's really scary also when they're actually having an active STEMI in the ER and people say, oh, we think you're okay. No one really delves into the EKG too closely. And I can think of a few times where it's led to some pretty catastrophic events. We don't always expect it in young patients. And with a lupus patient, even though it's not that common, you should.
Right, exactly. I think we think, oh, young women, that's, we don't
Right.
think of cardiovascular disease. So I think it's really important to get that word out. I know, cardiologists and rheumatologists, I think, are having a increased understanding of this risk, but I think it's important for everybody, including patients, to understand so that they know to seek help if they're having symptoms.
Right. And young people mask things really well until it becomes catastrophic.
Yeah, exactly. That makes it so scary. We've known for a while that there's been this increased risk in cardiovascular disease. And I think, the first time we understood this was in 1976 from the Toronto lupus cohort, where they saw that there was actually a bimodal pattern of mortality in lupus patients. And they saw that although, of course, at first deaths from lupus were related to the disease itself or organ manifestations or infections, there was actually a second peak of deaths at about 8.6 years that they saw still increased from infections, but also cardiovascular disease. And I think, multiple studies have gone on to demonstrate that increased risk. And most recently, we have data from the CDC registries. We know from the California Lupus Registry that they found that overall lupus patients had a 3.6-fold increased risk compared to the general population. And, we also know from your area, the Manhattan Lupus Project, again, it's very similar, threefold increased risk for cardiovascular events in lupus. And then again, what we were just discussing, they found that in 20 to 49-year-olds, the overall prevalence ratio, there was a 6.4-fold increased risk in lupus in general. And in male lupus patients in that younger age range, up to 11.3-fold increased risk.
Data's out there, right? It's just making sure that everybody knows it and applies it, so to speak.
Yeah, exactly. And again, as we said from the outset, remembering that even these younger patients that we think of as being, not at typical risk, I think are at higher risk. I know, certainly our lupus patients, we have them on medications that can change their lipids and cause high blood pressure, et cetera. And we can talk about all those things. But I think there's also really a role for inflammation. And I know there's a study from John Esdell's group that even after they controlled for all traditional cardiovascular risk factors, they still found a 7.5 to 10-fold increased risk for cardiovascular events. What can you tell us about the role of inflammation in the development of atherosclerosis and plaques?
I think that fundamentally inflammation is involved in almost every stage of atherosclerosis. And I have these conversations all the time with my patients in the cardio room clinic where I describe it as exposure over time. And so, an interaction between damaged endothelium or damaged blood vessels, the immune system, and dyslipidemia or lipids. And if you have an acceleration or an elevation in any one of those processes, it takes less time to develop atherosclerosis and, frankly, atherothrombosis, which is that plaque breaking off and platelets jumping onto the plaque and causing an acute MI. And so, first, the blood vessels have to become damaged and then become damaged by exposure. So, they can be damaged by the immune system itself, by hypertension, dyslipidemia, diabetes, etc. And once the endothelium becomes damaged, circulating lipids can go and can adhere to the endothelium, can translocate through the endothelium into the intimal space. And the immune system comes and says, hey, you shouldn't be there. And so they eat the lipids, they phagocytose lipid particles, tries to get rid of it. But they don't do a very good job. And so I think a lot of us are jumping onto this concept that we call failed efferocytosis, meaning you cannot effectively clear those lipid particles from the intimal space. And so these macrophages secrete more pro-inflammatory cytokines, attract more immune cells into the plaque, and it creates a snowballing effect. So if you have a heightened immune system at any stage, that will, of course, increase the initiation and the progression of atherosclerosis. Not to mention, then, you can have atherothrombosis, which is the MI, which is, again, where that plaque can develop in the necrotic core, can become unstable, can break off, and cause that MI event.
Yeah, I think I'm always struck when I read this, how even some of the same cytokines that we think of as being involved in disease pathogenesis, whether it's lupus or rheumatoid arthritis or psoriatic arthritis, can be involved in atherosclerosis.
Yeah, I describe it as almost these causal cytokines or these causal immune pathways, but then also these bystander ones that may not be involved in disease pathogenesis, but are clearly upregulated in certain conditions, say like IL-6, IL-1, in our causal atherosclerosis, but it doesn't assume that targeting them will reduce the disease such as lupus.
We had done a lot of studies in our group also, even looking at things that we would typically think of as being protective. So, for instance, HDL, which normally can be protective against atherosclerosis in settings of inflammation like lupus, can actually have the opposite effect or not be able to effectively clear away those lipids. So again, that's very similar to what you were describing as well.
Right. And I'm surprised in a lot of these inflammatory conditions, there tends to be a lower HDL and impaired HDL efflux capacity, whether it's lupus, RA, or psoriasis. It's amazing the consistent patterns that you see across so many of these diseases, despite such a different disease pathophysiology.
Yeah, absolutely. So, given that, I'm curious to know when you see a patient in your cardio room clinic or a lupus patient that comes into your cardio room clinic, how do you usually approach them? How do you screen them? What kind of modalities do you use to determine their risk?
We first take a family history, try to understand their lifestyle, their dietary patterns, the exercise patterns, sleep, smoking, which is obviously incredibly important, etc. Then we make sure that they've had the traditional risk factor screen for, and that's a really, really important step, such as their lipids, their hemoglobin A1C, blood pressure, etc. So I think what happens a lot of time with these patients is they're so busy dealing with their lupus. It's such an important and critical part of their life that the blood pressure is sometimes, okay, we'll deal with that the next visit, or
Right.
they haven't found time to address their lipids or address their hemoglobin A1C. So we first screen for the traditional cardiovascular risk factors, and then I generally calculate a cardiovascular score. And most of that really entails, in my mind, understanding their age. Age, like I said, everything's exposure over time. So if you've had a high exposure to systemic inflammation plus lipids plus diabetes, well, then you need a heck of a lot less time. And then so I'm really going to start to be very aggressive at an earlier age. But if you've had less of an exposure, then I may start to be aggressive a little bit later in life. And the cardiovascular risk score kind of helps us take into account the different combinations of age plus traditional risk factors. And after that, if it's not immediately obvious if they need something more than general counseling on diet, lifestyle, and exercise, then I'll oftentimes default to imaging. And even if it is obvious, I oftentimes do like to get or talk about the potential use of imaging in many of these patients. And this is especially true with a young lady you were describing early on. A lot of these patients are young. And even though they're used to being on certain lupus medications for lifelong therapy, it's still a big deal to add another lifelong medication. And so I oftentimes find that if we get advanced imaging or just imaging in general, and we show someone the quantitative evidence of atherosclerosis of coronary of plaque, it really helps the patient buying into this process and saying, yes, they are at risk. After we get the traditional risk with the traditional risk factors and we calculate the risk score, we'll discuss imaging. And so the most conventional approach is a coronary artery calcium score.
Mm-hmm.
So I'll frequently talk about that. The problem is in young patients, again, it's exposure over time. It takes a long time to develop advanced atherosclerotic plaque, specifically calcific plaque. And so the hardest patients to risk stratify, I think lupus in particular, is in the young patients. Are you going to get a positive coronary artery calcium score in a 25-year-old lupus patient? Or if you don't, is that going to be enough to say, okay, you're not really at risk? Let's focus on lifestyle, diet, and exercise as opposed to being very aggressive. And I've actually found that the rheumatologists with the lupus literature have done the best job of understanding soft plaque. And so I actually am very aggressive about getting carotid ultrasounds in my lupus patients.
Oh, interesting.
Not so much for IMT, but really for carotid plaque.
And can you talk a little bit about the soft plaque for those who maybe don't know as much?
Once you get lipid deposition into the intimal space and you get macrophage phagocytosis, you get this fatty streak, and that's the initial stage of atherosclerosis. And as that progresses, you get more and more inflammatory infiltrates into the area. You get remodeling from smooth muscle cells, proliferation of smooth muscle cells. The smooth muscle cells turn into macrophage like themselves. You start depositing certain substances into the intimal space, one of which is calcium. That process can take decades to develop. So calcium remodels on the outside of the blood vessel. It doesn't necessarily mean that you're in the lining of the blood vessel. It doesn't necessarily mean that you have an obstructive plaque. It just means you have a high lipid burden. Because if we see calcium, we know that there's atherosclerosis in your blood vessels. It takes a long time to develop calcium. Calcium is not the thing that breaks off and causes a heart attack. It's the soft plaque. It's the plaque that calcium is representing. We worry that if we don't see calcific plaque, is that good enough to say that we see no plaque whatsoever?
Got it.
There's been this concept for a while that patients with autoimmune conditions may have a higher prevalence of soft plaque compared to calcific plaque when compared to other non-immune patient populations. So we're always worried that we're missing, that our coronary calcium scores may not be perfect or as good as in the general population. Now, as it turns out, I do have a colleague of mine who's studying this in Boston, and there's data that's been submitted at publishing abstract forms, so I'm going to talk about it, showing that in patients with lupus, RA, or psoriasis, they still are predictive of cardiovascular events. So that's another reason why I still start with my calcium scores. But if the calcium score is negative, I'll oftentimes default to carotids to assess for plaque.
And to see if there's plaque there. Yeah.
Right. And if there is, then I say the cat's out of the bag. This is no longer just a diet, lifestyle, exercise thing. We want to stabilize this plaque. This means you have systemic atherosclerosis. It's time to go on to be very, very aggressive with your care. And that oftentimes means a statin or aggressive lipid-lowering therapy.
Got it. Yeah, that seems like a really reasonable approach. Can I go back a minute to thinking about some of the risk assessment tools? I know I've tried to use these in my patients a bit, and I am a little limited by some of the more traditional scores we use, like the ASCVD, because they have a lower age range limit. Some of the patients don't even qualify at all. I was wondering if you have an approach or if you use a modified score or if there's a tool that you like best in these patients.
Right. Well, as you know, there are lupus-specific scores. There's been a few that are developed from people in the United States, and there's actually the British have one as well, where they add a multiplier to their risk score to get the real risk score in lupus patients.
Right.
What I like about these scoring systems is not so much the utilization. I don't use them. Maybe I should, but I like them because I look at the lupus-specific values that they put into the score. For example, a lot of these scores tend to have a history of renal disease in there.
Right.
So if you've had renal disease, the need for steroids, maybe not that you had steroids, but that your disease was severe enough where you had to have a chronic need for steroids. Persistently low complement, persistent elevations in antiphospholipid antibodies, persistent elevations in double-stranded DNA. I feel like these are you could tell me, but I feel like these are biomarkers of lupus disease activity that have persistently popped up across many of these scoring systems. So you're right. In addition to the advanced imaging, I oftentimes look at some of those serological lab values or renal function to understand how at risk they are and to determine therapies.
Yeah, great. All right, we have a patient who, we've determined has evidence of plaque, or you think that they need some intervention. What are some of the things that you use to manage? I guess first starting with some of the lifestyle recommendations. Exercise is always a challenge in this population, et cetera. I wonder if you have any tips.
It is a challenge. I always say to my patients, you should try to do enough exercise where you feel just breathless.
Mm.
So a lot of patients say, "Oh yeah, I go to the gym. I do exercise 2 or 3 times a week." Well, what do you do? I'm on the treadmill or I walk. And I'm like, "Well, could you have a normal conversation with me while you're walking?" And they say, "Well, yeah, of course." So that's great that they're being mobile. And I think even for a lupus patient, as you pointed out, that can sometimes be a really big win. But in terms of the exercise, I ask them to try to strive for it's doing enough work where you can have a full and comfortable conversation. And even if it's for 30 seconds and then you back off a bit. So that's what I try to counsel patients to do. And I find that somewhat helpful.
Yeah, I like that because I think it allows for a lot of patient variability. There are some patients
Right.
who will be, get that just walking, and there are other patients who will, really need to do a little bit more aggressive exercise to
Right.
reach
And also with your lupus patient, a lot of times, if there's chronotropic incompetence or a little bit of the resting heart rates can actually be kind of high sometimes.
Yeah.
Oh, we'll get to 85, 90% of your predicted heart rate. Well, they may not be sure what that is, but the resting heart rate may already be there. So I think having some kind of easy ways for them to self-monitor can be helpful.
Yeah, that's great. And then of course smoking cessation is important. I
Yep.
think we all know that.
Yep. Of course.
Hypertension, what are your targets that you usually strive for?
I find blood pressure can be challenging to get you at the optimal measure because you don't want to overdo it. But I often do try to shoot for sub 130, over 70, or under 80. Really try to. I do a lot of home blood pressure monitoring. I think that's really where there's missed opportunity. So we're lucky enough at NYU to have home blood pressure monitors that I can send the patients home with, and they can get a 24-hour read. So I do that a lot. But the other way, as I say, blood pressure cuff, check it a few times a day for 3 days and send me the average, and do that every few months. And I find it's a happy medium of not driving them crazy, but also not missing any severe elevations that can occur over time that we're not treating. And I like the average to be under 130 over 80. And if it's not, I treat them.
I think that's a really reasonable approach. And then, of course, treating dyslipidemia. What's your approach to using statins in patients? I know that we've had some actual randomized clinical trials in lupus patients, one that Michelle Petrie did in adult patients, and one that was done in the pediatric population, and neither one were positive studies. But I think the cardiology studies in the general population were quite large, not 200 patients. So anyway, what's your thought on the statins and how you approach it?
Right. Well, as you alluded to, talking to a cardiologist, you get somewhat of a biased approach to it.
Right.
I think most of us feel that they have a really, really good safety profile. They're highly effective, at least we know in the non-lupus patient population. And I think that if you do find plaque, coronary calcium, I'm very aggressive about statin therapy. If they have other traditional risk factors, I'm very aggressive. Obviously, diabetes is a class 1 indication, also
Sure.
out of statin therapy. There's so much low-hanging fruit there. There's also some nuances, right? I mean, especially in a predominantly female disease that, statins are contraindicated in pregnancy.
Ah,
So you have to understand who the patient is, what are her goals, what are her short and medium range goals. For example, there are some statins that have more issues in when patients are on dialysis. So there's some nuances as well that I counsel them about. But I'm pretty liberal with statin therapy. But I want the patient to buy in. It's a long-term medication for them.
right. I think those are really important points. And yeah, again, having the patient be on board and considering all of their future goals and lifestyle needs, I think is really important too. What are your thoughts about colchicine? I think that's a newer medication in the cardiology world, but in the rheumatology world, we're familiar with it in our toolbox from treating our crystal disease patients. But I think the idea of using it in cardiology patients is a little bit more novel.
There's been a lot of chatter about colchicine recently, kind of starting with some seminal clinical, I think, very important clinical trials in cardiology in the non-autoimmune patient population showing benefit with stable ischemic heart disease to reduce events and leading to FDA approval for colchicine for the prevention of cardiovascular disease, or secondary prevention. A similar indication to statin therapy. Then we had a really, really large clinical trial called Clear Synergy that showed no benefit in the acute ACS setting or the acute MRI setting of putting colchicine on, but for long term, for several years after the event. But that clinical trial had some issues, and it happened during COVID, and there was some enrollment questions. So in my non-autoimmune patient population, I do use it when appropriate. I find it really, really useful when you're not quite sure why the patient had an MI or why the patient has so much atherosclerosis burden, meaning the lipids are okay, they're not a non-smoker, et cetera.
Got it.
In the autoimmune patient population, we're talking about just for ASCVD, of course, not for other colchicine.
Right.
We're not quite sure with colchicine the benefit when you're already on other immune modulators. Clearly, if they're just on, say, hydroxychloroquine, they're high cardiovascular risk and they have bad athero. I think that's someone who I'd feel pretty comfortable if they need it. But if they're on multiple immune modulating medications, high dose steroids, so many medications, I really have not been aggressive about adding it. I've went more towards statins, blood pressure. Weight's a really big one.
Yeah, great. I think that's really helpful. And, you mentioned hydroxychloroquine. That's something we haven't talked much about, but I think we're getting more and more data, from at least large observational studies that hydroxychloroquine may play a role in being protective against cardiovascular disease also for its antithrombotic properties, most likely, but perhaps anti-inflammatory properties also.
I'm getting more aggressive about screening for potential cardiotoxicity, similar to the way that you guys look at it, have guidelines for ocular recommendations. I think it's somewhat under-recognized.
Yeah.
So I think just understanding the patient and, I guess, assessing their EKG, any heart failure symptoms, et cetera, can be valuable just to make sure, especially if they're on for 20 or 30 years.
Yeah, great. I think that's really helpful. Just real quickly, I know we've talked a lot about atherosclerotic cardiovascular disease. I think that there are some newer approaches to treating disease manifestations such as pericarditis also. Do you have any approach to lupus patient with chronic pericarditis?
I would say it's a very exciting time in the pericarditis world. The most important approach is actually partnership with a rheumatologist, because I think we're trying to figure out what medications are okay versus maybe not okay to combine with some of the newer immunosuppressive medications in pericarditis. And plus also, my first approach is talking to the rheumatologist and understanding, is there active disease, active lupus beyond just the pericardial inflammation?
Mm-hmm.
Because if there is, then I think that's really should be driven by, that is driven by the rheumatologist, right? And then they can come to a chat, and many times it's treating the underlying disease, treating underlying lupus. But I feel like we've seen, I'm sure you could teach me, but I've seen a number of patients where it seems that the only active disease has been the pericardial component.
Yeah, I have several patients like that.
And for those, the rheumatologist will come to me and the colleagues like me and say, hey, everything else is really quiet. They've been quiet for years, but it's just the pericarditis keeps coming back and back and back, or can't get them off 10 a pred or 20, 15 a pred, and they're on colchicine. And so I feel like for those patients, we've had newer FDA-approved medications out there that are targeting the IL-1 pathway, specifically rilonacept. We've seen some really, really dramatic benefit. The hard part is if the other disease manifestations come back, we're not quite sure how to balance that. So I think we're trying to figure it out. But I've seen some really nice resolution of pericardial disease with these IL-1 inhibitors in the lupus patient population.
Yeah, I've had similar results in those patients that had otherwise been really difficult to treat. Great. Well, that's really helpful. I've really enjoyed our discussion today, and I want to thank you. Today, we've talked to Dr. Garshick about cardiovascular disease and lupus. And for our audience, please take a moment to download the Medscape app to listen and subscribe to this podcast series on systemic lupus erythematosus. This is Dr. Maureen McMahon for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Systemic Lupus Erythematosus podcast series with our host, Dr. Maureen McMahon. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on systemic lupus erythematosus.